more people will be.
Would you like me to share the PowerPoint at this point, Barb?
In a minute, I'll tell you when. So I just want to say good afternoon to everybody, and thank you for joining us for this webinar on fostering trauma-informed care with Pete Cudney. And I just want to remind people this is presented as part of VCHIP's ongoing work to support practices in providing timely, comprehensive care for children and youth as they enter foster care. And we can go ahead and show that first slide, Pete.
Okay.
Thank you so much. I just wanted to remind folks that the AAP guidelines recommend an initial health screening and a comprehensive health assessment within 30 days. And these visits allow opportunities to provide anticipatory guidance around parenting a traumatized child. Next slide. And in addition, the AAP recommends an enhanced well visit schedule, which allows for ongoing support and education for foster parents. And next slide. I just wanted to give a shout out and remind people that the Vermont Child Psychiatry Access Program, or CPAP, is now live, and this slide provides information on how to register. And next slide. It gives me great pleasure to introduce Pete Cudney. Pete is a licensed clinical social worker who's practiced clinically in the area of child trauma for over 25 years. His practice has included wilderness-based therapy, residential treatment, individual and family therapy, and comprehensive trauma evaluations. Pete is certified in the use of EMDR and in the neurosequential method developed by Dr. Bruce Perry. Currently, Pete is a staff member on the Child Welfare Training Partnership at the University of Vermont, and he offers training and clinical consultation through Cudney Consulting. And I'm just going to throw out some quick housekeeping reminders. Be sure to mute yourself and turn off your video during the presentation. Please put questions in the chat as we go along, and there'll be time to answer these questions live and other live questions at the end. And you'll also receive an email that will have the slides as well as information on how to access a recording of this webinar. So take it away, Pete.
Excellent. Thank you so much, Barb. Hi, everyone. I hope you're doing well today. It's such a privilege to have some time to talk with you. I have a lot planned for an hour, so hopefully we'll be able to get through all of it smoothly. The objectives that I'm hoping to cover begin with a basic review of some of the terminology around trauma and complex trauma. I'd love to explore with you the range of potential impacts, including just a few short case examples. I'd like to offer some possible interview questions that you could consider weaving into an office visit, and then discuss some specific trauma-informed engagement and resiliency building strategies. We'll have time at the end for Q&A, but please feel free to use the chat along the way. Barb and Jill will monitor that, and I'll periodically try to check in to see if there are any questions that would be best answered in the flow. And the final slide that you'll get in the PDF handouts has hyperlinks to a lot of the resources, if not all, that I reference in here as well. I do not have any financial or non-financial relationships to disclose relative to any of the material that I'm presenting today. So to begin, terminology that's used in the field of child trauma can sometimes be confusing. So I thought it would be helpful to begin with some level setting language. Foster parents may also find the language used to be confusing, and so this might be really helpful in conversations with foster parents. So I like to begin my conversations with families by talking about adversity, just framing adversity as challenges that we face in life. Adversity isn't necessarily bad, right? We need to face adversity in order to grow, in order to get stronger. If you go out on a weekend to hike Camel's Hump, you're going to face physical adversity of getting to the top, but it can make you stronger. Stress is our physiological response to adversity, and stress can range from healthy stress. That's when it's patterned and predictable, just beyond our current capacity to cope with it, and followed by rest. Healthy stress makes us stronger over time. Stress that is more intense can be tolerable if it's in the presence of supportive network of relationships. And of course, stress can also be toxic. Toxic stress is both stress that is so acute in the moment that it's beyond our current capacity to cope with it, and especially when we fear for our safety. And so that type of toxic stress is the kind of stress that can come with a single incident traumatic experience that can lead to something like PTSD. But toxic stress can also include chronic stress without time to recover, and especially in the absence of supportive buffering relationships to mitigate that stress or help someone make sense that they're still safe and secure. Trauma, I believe, is best understood as a stress injury. It's when a person's brain and nervous system have changed in response to some type of toxic stress. Trauma and toxic stress can impact an adult, but the way toxic stress impacts a child, if they are exposed during early childhood when there's foundational neurodevelopment happening, is a different phenomenon. And that's referred to as complex trauma or complex developmental trauma. So when stress is toxic during childhood, it can lead to foundational changes in neurodevelopment with potential long-lasting impacts across all developmental domains. No doubt you're familiar with the initial ACEs study published in 1998. That was a study conducted by the CDC and Kaiser Permanente. Doctors Faliti and Anda and others conducted that study, and they found a dose-dependent relationship between the doses, if you will, of adversity that a child experiences and the potential that that child will, as an adult, have later physical and mental health problems. So they found that the more adversity a child experiences, the greater the potential risk of physical and mental health outcomes down the road. Following that study, the publication of that study in 1998, the field of child trauma research has really ballooned. The research has become much more nuanced, looking at ways of measuring stress in finer detail. And a number of active groups in that include the National Child Traumatic Stress Network, NCTSN, Harvard Center on the Developing Child, the Trauma Research Foundation, that's Dr. Bessel van der Kolk's group out of the Boston area. Child Trauma Academy is Bruce Perry's group, and Dr. Dan Siegel with the Mindsight Institute. Hyperlinks to all of these organizations are on the final slide of today's presentation. In 2003, the Complex Trauma Task Force of the NCTSN published their white paper, Complex Trauma in Children and Adolescents. And that was a meta-analysis of research that had been done up until that time, where they looked at what are the impacts that we are seeing for children, predictably, who are experiencing complex trauma. And they identified, based on that meta-analysis, 7 domains of potential impairment that we then use to organize our assessment of impact and also our treatment planning based on a child's current functioning. So those 7 domains of impairment include attachment and relationship capacity in general, a category for biology, which really refers to autonomic nervous system functions, digestion, skin and hair health, systemic kind of biological functions, affect regulation, so a child's ability to manage their stress levels, to have language for their emotions and strategies to regulate their emotions, the potential for dissociation, a child's executive functioning and therefore their ability to inhibit behaviors as well as adaptive behaviors that they've developed in response to stress, the child's cognitive functions, which include language development and include attentional functions and other executive functions, and then the child's self-concept. So again, we want to organize our assessment and our treatment planning based on these 7 domains. Diagnostically, we're in a little bit of a tricky place. The DSM-5 does not have a single comprehensive diagnosis. Some have been proposed, none have yet been adopted. I'm certainly hopeful that we move in that direction. The ICD-11 has a diagnosis available of complex PTSD that gets at most of this phenomenon of complex developmental trauma. But as you know, in the United States, mental health providers typically use the DSM-5. And so in the absence of a single diagnosis, one of the kind of sentinel indicators that we might see for a child or a youth is a collection of other diagnoses that have been given that may align with some of these domains. So it's not uncommon for a child with complex trauma to have a list of diagnoses that include reactive attachment disorder, sometimes a sensory processing disorder, very frequently some kind of a mood disorder, anxiety, bipolar, depressive disorder, something like that. If they are dissociative, usually that gets missed. But if it has been diagnosed, there may be a specific dissociative disorder diagnosis. They may present with non-epileptic seizures without some kind of understanding of what's causing those seizures, if it's really profound dissociation. And sometimes children who develop dissociative patterns present as if they are on the autism spectrum. Very frequently, children come with some kind of behavioral diagnosis, something like oppositional defiant disorder, intermittent explosive disorder. Again, very common to see an ADHD or learning disability diagnosis. And then in terms of self-concept, it's usually just a core sense of shame. And so if you see a child who has experienced high levels of adversity early in childhood, and they come with a number of different diagnoses like this, these may really be trying to get at a larger phenomenon of complex developmental trauma. The American Academy of Pediatrics has identified children in foster care as children with special health needs. So what we want to keep in mind is that when adversity and stress are high during childhood, and when there's a lack of responsive primary caregiving and other supportive relationships, it's likely that a child will experience some impacts of complex trauma. So high ACEs and low protective factors place a child at high risk. Statutory and policy thresholds for DCF that are necessary for a child to actually be taken into custody and placed in foster care are very high. Children who have come into custody and been placed either with kin or foster providers have very likely experienced some degree of physical or sexual abuse and or neglect. And so we almost know by definition that a child in foster care has experienced high ACEs and some disruption to their protective factors. The level of severity of that impact for any individual child will vary based on unique factors. Those would include the nature of the adversity that they experienced, the duration of that and the intensity, how protective were the buffering caregiving relationships that they had, and the child's age at the time of their exposure. So those are all going to be factors in terms of the severity of the impact. So let me pause, lightning fast. I doubt it, but are there any questions that have come up in the chat just yet?
Hi, Pete, I don't see any questions right now.
Okay.
Thanks.
Yeah, maybe I'm going so fast that people aren't even having time. Please feel free to ask questions in the chat if you'd like to. All right, so with the framework of the 7 domains of impairment in mind, I thought I would offer some possible assessment questions for you to consider weaving into your practice. So I would think that with practice, you can develop a short set of interview questions that can help assess the child's functioning and also the caregiver's understanding of that child and the caregiver's relationship with the child. Obviously, based on the child's age, you would adjust your questions to either be directed just at the caregiver or to be youth-friendly if you're including them in the interview. Because complex developmental trauma occurs within human relationships, so abuse or neglect happen in human relationships, because of that, we want to assess the child's current relationship patterns and offer guidance to enhance the security of those primary caregiving relationships as much as possible. Beginning with strengths is critical. Children impacted by trauma often feel incompetent. And as a result, they may be very self-protective. They may be very avoidant of new growth opportunities. By beginning with and really intending to identify what I sometimes think of as their islands of competency, those activities that they feel successful in, those relationships that they feel secure enough where they do turn to those people, by identifying those areas of competency for the child, we can carefully try to build challenges based on those that the child may feel safe enough to engage in. So a child's favorite activities, for example, if one of a child's favorite activities is playing basketball, then I would want to strategically talk with foster parents about using basketball as an opportunity to build relationship together. How can you, when the child is maybe too overwhelmed or stressed to begin a conversation, how can you use dribbling a basketball, passing it back and forth, taking turns shooting hoops while you're just quietly with that youth as a way, as an on-ramp, so to speak, for a relational engagement? What does the child already prefer to do when they're feeling upset? What are their tendencies when they're feeling overwhelmed? That can both be assessment for us about any problematic patterns and also any healthier coping strategies that they do have. What relationships does the child feel comfortable within already? And what is the child most proud of? And what about the child makes you the proudest as well? So we really want to begin with strengths, not just as a passing reference to strengths, but really to try to build as much as possible, keeping in mind that those are the areas where the child may feel secure enough to try something new and to have a growth mindset. Having said that, we also want to ask about adverse childhood experiences. And again, these questions are probably tailored primarily for a conversation without the child present. In a minute, I'll offer another resource from the National Child Traumatic Stress Network that can be helpful for talking with youth and caregivers together. But what have been some of the most stressful factors in the child's life in the past year? Do you know about stressful factors in the child's life prior to that? The more we can get foster parents thinking about the child's previous adverse experiences, the more we're setting the stage for them to be able to think about that child's behaviors and interactions in a trauma-informed way. Are you aware of any unsafe, scary, or very upsetting experiences the child has had? We should pause to note that being taken into custody and being placed, even if it's with a known kin provider, and certainly if it's placed with an unknown foster provider, is a stressful, scary, and upsetting experience for a child. And so we'll want to make some space to talk about that transition. How has that been for the child? And in particular, does the child talk about any particularly upsetting life events? Are there certain indicators that the child has a traumatic memory associated with specific events? So strengths to build on, history of ACEs to begin with. Then I would suggest that we move to thinking about the domains of impairment. And you might want to include a couple of questions that get at how well the child seems to do at understanding and navigating human relationships, relationships with adults. How about relationships with peers? Does the child have friend groups? Has coming into custody and being placed with you meant that they have changed schools? Have they changed communities? Have they lost access to those friends? Or do they still have friendships? Do they have one friend? Do they have a network of friends? Who does the child seek out for support when they are overwhelmed or upset? Healthy relationships are the primary mode of treatment, if you will, for recovery from complex trauma. When children have experienced human relationships as a source of threat, when they've experienced human relationships as failing to be predictable and meet their needs, What they then need to recover from those experiences is to have the opposite, to have human relationships that are responsive, that are safe, that are attuned, that bring them pleasure and excitement. And so the more we can orient foster parents toward the importance of relationships and the importance of trying to build as many healthy relational connections for that child as possible, the more we are naturally moving toward recovery for the child. So then you can see that these parallel the 7 domains identified by the NCTSN. We may want to ask about the child's sleep, their eating patterns, digestion and elimination. Do they have any particular sensory preferences? How are they doing in terms of motor coordination, motor development? Anything else that would be a systemic biological issue is something that's worth noting in here. Affect regulation. Do you see a full range of emotions from the child? Some children become really numb and somewhat constricted, and they don't show a lot of emotional range. Other children's emotional range is very, very broad, but can be really intense, and they may have a lot of difficulty regulating that emotion. In particular, when they're very excited or when they're very sad or upset, what does that look like? How long does that typically last? Again, this is for your information about the child, but also in a conversation with a foster or kin provider. Hopefully you are starting to orient them to pay attention to the child's state of arousal. Children impacted by complex trauma really struggle with self-regulation. They are still developmentally much younger and therefore still frequently dependent on adult co-regulation. And so in the same way, a toddler will be upset and will not be capable of understanding why they're upset, thinking their way through it, regulating those emotions, but instead will need a caregiver potentially to scoop them up and to co-regulate them. Older children who may have experienced complex trauma are still more dependent on adult co-regulation. And so by orienting foster parents toward paying attention to the foster child's level of stress and emotion, again, we're setting the stage to try to help them provide co-regulation for the child. Dissociation is, I think I mentioned this earlier, it's frequently one of the domains that can be missed. And that's simply because when a child slips into a more dissociative state, they tend not to be behaviorally disruptive. They have entered into their own internal reflective kind of fantasy world, if you will, become less connected to their self, to their environment, to relationships around them. So a child who dissociates in school may be very daydreamy, maybe looking out the window, maybe missing the cognitive information about math or about American history, but they're probably not as likely to be poking the child next to them, flipping their desk over, right? So children who exhibit really amplified behavior problems tend to be noticed. So dissociation, we want to be asking about, do they just kind of disappear into a daydreamy state? Do they seem to be lost in thought? As teens, and I know all teens probably to some degree prefer to lose themselves in books, media, or video games, but some children really, really tend toward that dramatically. They have experienced the world to be unsafe and unpredictable. They have experienced human relationships to either be harmful or there to be an absence of humans caring for them. And so they've become disconnected from the external world as a means of reducing the stress and become much more focused on their own internal world or fantasy. I've seen children on the playground, elementary school age children on the playground who walk around on their own, telling themselves a fantasy story, acting that story out without interacting with other children. They're in a more dissociative kind of a state at that time. For teens, use of substances and self-harm can frequently be associated with either trying to induce a dissociative state using substances to feel less, or to regulate dissociation. Sometimes teens will scratch, burn, cut themselves in order to bring themselves back to the here and the now. If they're dissociating and they are experiencing a memory an intrusive memory of a traumatic event from the past, if they're experiencing overwhelming shame, sometimes they will turn to self-harm because the intensity of that physical experience brings their attention back to the here and the now. So substance use and self-harm can be associated with dissociation. Continuing with the domains of impairment, you'll want to ask about, do you have any concerns about the child's behaviors? This is often where foster parents or other caregivers will begin with the child's behaviors. So we want to know about that. Do you have any guesses as to why the child might be behaving this way? So at this point, you may be assessing how much is this provider thinking from a trauma-informed lens? How much education do they actually need in order to understand that this particular behavior may go back to some traumatic experience from the past? And then I think this is a really important question. One of the problems that we know about when children come into custody is that they can then bounce from placement to placement. And typically what leads to that is some problematic behavior pattern that that child exhibits that the foster parents aren't prepared to live with and don't understand, and it can bankrupt that relationship. So are there any behaviors in particular that you've seen from the child so far that you worry might impact your ability to provide for the child in the long run? Cognition, what is the child's attention span like? How well does the child communicate with you, both expressing their thoughts and accurately understanding your information? How is the child doing in school? Do you have any concerns about the child's ability to learn? And then self-concept. What would you guess? Would you guess that this child feels proud of themselves? Are there times you think the child may worry that others don't like them? So these are simply examples. My hope is that with some practice, with the 7 domains, with the history of ACEs, and with the strengths as a framework, that you might be able to create a relatively short set of interview questions that can fit within the scope of an office visit. The NCTSN has so many resources. So if you're looking for resources, their website would probably be the first place that I would recommend going. This is a resource, a PDF that they have available free to download. There's a hyperlink at the end that takes you to the NCTSN's website. And I believe I may have put a link specifically to this PDF resource. So this is, I think it's around 20 pages long, and it is written with youth and their caregivers in mind. And it's written in such a way that it could be read together with a care provider and the youth. And it includes teaching information about what is trauma, what is complex trauma, how does it potentially affect you. And it includes activities like this worksheet that can help you enter into a dialogue with a youth, or can help a foster parent enter into a dialogue with a youth that really pulls them collaboratively into the process of self-reflecting and planning. So I'll pause once again and see if there's anything in the chat that we should attend to, Jill.
Hi, Pete. Yeah, there's a question that's often asked is how in medical practices, when people only have 15 minutes, would you prioritize these questions?
How would I prioritize the questions? I think that I'll go back, at an initial visit where the foster parent may not really yet know the child all that well. I think in those early visits, I would be really focused on strengths to build on. And I would be focused on how has this transition been going so far. In a follow-up visit, I think I would probably try to request some time with the caregiver without the child if the child is older. And at that point, then I would begin focusing on what at this point have you learned about this child's history of adversity, and start to move into domains of impairment. And the 2, if I had to choose, I guess I would say 3 would be attachment. I would really want to know about relationships. I would very much want to know about affect regulation. and I would very much want to know about behaviors. Behaviors are often a child's communication to us about opportunities for interventions. And so we'll move a little bit more in a couple of minutes to what I mean by that. Anything else in the chat for now, Jill?
Yeah, so one more, and then I know for the interest of time, we've got to move along, but how would you utilize some of these assessment questions and activities for babies or toddlers that are in foster care, as well as their foster parents?
Excellent. So with very, very young children, coming back here, obviously, you know, if they're very young, the strengths may be more about just where are they at in terms of developmental milestones. I find the milestone tracker app and pamphlets to be really helpful for that. I'm sure in pediatric practices you have your own ways of assessing developmental milestones, but I would really want to be learning about developmental milestones. And then I would really want to focus on primarily affect regulation. What are you seeing from the child in terms of their level of stress? What does their baseline level look like? How frequently are they seeking some kind of interaction with adults? How frequently, when they are upset, do they allow your efforts to soothe them to actually be effective? With very young children, what we're looking at is still primary attachment formation. And so if what they have experienced is that when they have a need and they cry, a caregiver is present, the caregiver responds relatively quickly, and that caregiver has their own coping skills to maintain their own calm affect, and they can therefore soothe that child effectively. If a child has repeatedly had that kind of attuned, co-regulating response, then they will likely be capable of engaging with a new person, a kin provider or a foster parent, in a way where when they are upset, they're inclined to communicate that and they're able to be soothed by that other person. What we sometimes see instead is that a child doesn't really display affect when they're upset. They become dissociative from that, or they display powerful affect. However, when a caregiver tries to soothe them, even if that caregiver is regulated and offering co-regulating, maybe rhythmic, sensory motor kinds of experiences, the child may not be able to be soothed by that. So I would want to be asking a lot about how well do you understand this child's developmental capacity, how well do you understand their current developmental needs, and how successful is this adult and this child at co-regulation. And then I would really want to orient them toward learning how to co-regulate this child, how to maintain their own calm, even if the child continues crying, continues crying, continues crying, continues crying. How do they just stay calm themselves in order to help with that? Excellent. Great, great questions. All right. So moving on from this resource, this gets at a little bit of what we were talking about. Because trauma is relational, all of our interventions include a relational component as well. And so I want to orient you toward serve and return concepts and attuned caregiving responses, and encourage you to help foster parents understand these concepts as well. So this is a slide that I could spend an entire hour on. I won't. I love it. It's based on work by Beverly James from her handbook for treatment of attachment problems, and I'll walk you through it. So if we begin up here at the top of this cycle, imagine a little one who wakes up from a nap and they have some needs. Maybe they have a hungry tummy and a dirty diaper, and that causes their autonomic nervous system to activate. They become stressed, and hopefully it's healthy. They enter a state of high arousal and they cry. And then in this healthy cycle, there's a caregiver who hears that, who stops what they're doing, who comes in, who scoops the child up, and they respond in an attuned way. So there's serve and return. The child cries, and the parent returns by attending to that. And they attune to what the child needs. So there's behavior, crying, but their response isn't simply to stop that behavior, which could be as simple maybe as offering the child a pacifier or maybe a sweet drink in a bottle. The child might stop crying. But instead what they do is they take reasonable guesses at what might the child need, what emotional state might be underlying this behavior, and then their response meets the child's needs. So little one wakes up with a hungry tummy and a dirty diaper, caregiver comes in, scoops them out of the crib, feels that lump, that warm, sweet smell, gets them on the changing table, and in the process, co-regulates, meets their need, resolves some of the stress of the dirty diaper, the child relaxes on the changing table, and this attunement offers the co-regulation from a state of high stress to a state of relaxation. In this process, neurons that fire together wire together. And so with enough repetitions, what can happen is that a child can come to associate human intimacy. When I have a need, I communicate that to the world. When someone offers to help me with that need, I allow that to happen. Human intimacy is a good thing. It becomes wired together with stress relief, and it becomes wired together with pleasure. And so children come to lean into human relationships, right? So the caregiver meets their needs of the dirty diaper. They realize the child hasn't eaten in a while. There's another need. They move through this cycle again. And if you've ever raised a child, you know this happens millions and millions and millions of times. And sometimes those are physical needs. Sometimes they are cognitive needs. Sometimes they are meeting the child's emotional needs. Sometimes the child has been sitting in a car seat for too long, and it's the child's motor, gross motor or fine motor needs. So we want to orient caregivers toward the idea of serve and return, attending to the child, noticing the child serves, returning those, and decoding behavior in order to get at what's underlying the behavior, unmet needs and powerful emotions. If we boil it down to those skills, then most of the time we're offering the roadmap for maintaining relational engagement and co-regulation that will, over time, meet the child's developmental needs across most of their developmental domains. So attunement is about serve and return. It's about decoding. It's not just a response to the behavior. There's a really nice video from Dr. Jack Shonkoff from the Harvard Center on the Developing Child, and I've gotten their permission to share it with you. So it's just a few minutes long. Let's watch this.
I'm Jack Shonkoff. Did you know that the most important interaction you can have with your child is through play? Building your baby's brain sounds a little bit intimidating. So step back and take a deep breath. Parenting is much more of an art than it is a science. I'm Jack Shonkoff, and this is my mini parenting masterclass on building babies' brains through play. The early years are important in terms of brain development because the experiences that young children have and the relationships they have with the important people in their lives literally shape the development of their brain. And that early foundation affects all the learning and behavior and physical and mental health that follows through a lifetime. It's impossible to overestimate how important the early years are. The most important thing that any parent can do to support the development, and particularly the brain development of a young child, is to get to know that young child, get to be able to read that child's cues, get to be able to engage in what we call serve and return interaction. Serve and return is just like play. Another one, getting better. So this serve and return, you get better with practice. The reason why serve and return accurately describes what's important about the interaction is that it goes in both directions. A baby serves a smile, a coo, a babble, a gesture, And the parent or other adult caring for that child returns a response that is connecting to what the baby did. Baby makes a sound, you make the same sound back. The baby points to something, you look at that and you point to it yourself. That's the key. It goes both ways. The baby can start it, the parent can start it. The key is how you respond. Serve and return is not necessarily something that works the first time you try it, but the more you practice, it actually gets easier. For very young children, all important learning takes place within the context of play. Play is exploration. Play is trying things, trying to kind of figure out how when you do one thing, something else happens. Play is trying to develop a sense of mastery of the world. A lot of that is done by providing an environment that's safe and provides opportunities for learning. A lot of play, a lot of the interaction between parents and young children is in the serve and return category. I would start with making the idea of serve and return to be something that's easy and friendly and relaxing. Play can occur when you're feeding a child, when you're changing a child's clothing, when you're bathing a child. All of those are opportunities for playful interaction and learning between adults and children. To help parents understand that when you smile back and then not just stop there, but then start playing, you're actually building brain circuits. In infancy with very young babies, it's all about interaction, kind of visual, sound. It's looking your baby in the eye, making that personal connection, being sensitive to your baby's feelings. Here are some things people may not think of as games, but they're games, they're play. Peekaboo, putting a cloth over your head. Where's baby? Oh, here he is. Patty cake. How big is baby? So big. The best kinds of games create a sense of emotional safety that allows growth. When you cover your face with a cloth and play peekaboo, a baby is learning. Why is the baby still laughing every single time you do this? It's because first, it's the personal interaction. It's very rewarding. But second, the baby is mastering the concepts of things disappearing and coming back and knowing that they still exist. If a baby keeps wanting to do this, there's a reason for that. And the reason for that is that the baby's brain is saying, I am mastering this. I am learning a lot from this. I am enjoying the learning experience. Ask yourself, what does my baby enjoy doing? And then ask yourself, why do you think the baby enjoys doing that? And the answer always is because it is helping to build the baby's brain.
Obviously, this is critical for the youngest of children, but serve and return continues to be necessary in our relational experiences as children, as teenagers, and as adults. And a playful attitude toward whatever you're doing with a youth and the concept of serve and return, it needs to be adapted a little bit for a teenager. But to use the basketball example from earlier, taking turns, shooting hoops, and then passing the ball back and forth is a form of serve and return that can exist between a caregiver and an older child as well. Moving on, we really want to educate caregivers about how behaviors may reflect past trauma, and then encourage them to adopt a curious stance about challenging behaviors. We want to shift from why is this child acting this way to what may have happened to this child. We want to encourage caregivers to ask, how might this behavior make sense in the context of past trauma? What unmet needs might the child be attempting to meet through this behavior? We want to move caregivers away from punitive consequence-based approaches to parenting, and instead teach them that behaviors, even maladaptive behaviors, are a form of communication about the child's needs, and that our job is to decode those behaviors. So let me offer a couple of case examples really briefly. I consulted for a pre-adoptive family with a 10-month-old, and they proudly let me know early on. We knew that this child had experienced neglect, and they let me know that the child really didn't cry, that the child was very, very easy to soothe. We looked at that from a trauma lens, and we realized that that may actually be problematic, and that what they really needed to do was to try to keep that child engaged in interactions as much as possible, and that they needed to really, really be refined at noticing any of the slightest signs from that child that that child was communicating a need or any kind of distress, and respond pretty quickly. And with that over time, with that really heightened attuned responses, the child became more comfortable communicating her needs over time. I consulted with a school system, did a trauma evaluation, and consulted on a 10-year-old. And among other behaviors, that child would hide food, would drink water compulsively, but then also was wetting the bed almost every night. And that child's adoptive parents really struggled. They were trying to use rewards and consequences around bedwetting. And they were trying to understandably stop the child from drinking too much water. But when we looked at that child's trauma history, we understood that the child had had long periods of time where they were locked in a bedroom, where they didn't have access to food or to water. And so when they did have access to food and water, they compulsively felt like they needed to get it while they could, not knowing if there would be a time when they wouldn't have access to it. And so we chose to prioritize helping the child feel secure, that they would always have access to food or water if they needed it, and helping the parents tolerate and plan around this child may wet the bed for some time if they are drinking a lot of water before they go to sleep. And let's try to live with that. Let's try to manage that in a way that can work for your family, that the child doesn't feel ashamed of, and instead really orient toward helping the child feel secure, that their basic needs will be met. Once they have that level of security, perhaps the compulsive drinking of water will reduce, and then we can start to look at them not wetting the bed as much. I worked with a 16-year-old in residential treatment who pretty routinely engaged others relationally in very sexualized, seductive kinds of patterns. These kinds of patterns can be really problematic in foster homes, especially if folks don't understand where it comes from. When this child's family and this youth and we examined her history, we understood that she had had enough experiences of sexual abuse, that she had come to believe that it was likely to be inevitable in most relationships, that at some point the other person, especially if the other person had power, would initiate some kind of sexual request or demand from her, and that it was more in her control. The outcomes were less harmful to her if she initiated that engagement and had some control over it. And so with a 16-year-old, it was a lot of work for that young person to self-reflect. And then it was for the caregivers in our residential program and that young person's adoptive parents to understand that if she did behave that way with them, that it wasn't something to be punitive about, that it was something to remember, that's not going to be a part of our relationship. I don't feel upset that you did that, but let's be really clear about the nature of our relationship with one another. I'm curious if anyone would want to put into the chat any specific behaviors that have presented challenges in your practice. And I'll move forward with the slides, but if you'd like to, I'll try to maybe take a crack at decoding some of those other behaviors moving forward. Dan Hughes is an attachment therapist, researcher, and author. And he offers this idea of the perfect pace. And so this is really a framework for how we and caregivers might want to be mindful to position ourselves. Children who have experienced complex trauma do not necessarily believe that relationships are just good, that people have good intentions. They're very guarded often, and they will misinterpret at times others' affect, especially if that affect is negative or even if it's neutral. And so we want to practice cultivating positive, playful energy, facial expressions, tone of voice that really very overtly signals to the child, I'm excited to be in this relational interaction with you. I like you. I think you're pretty cool, right? So this positive, playful energy. Then we want to cultivate an acceptance mindset. We want to be accepting that this child would really love to succeed as much as any other child, and they're genuinely trying to be successful. They're not trying to get under my skin when they misbehave this way, and accept that many of their struggles may be related to prior events. We want to encourage caregivers to adopt a stance of curiosity. What may have happened to the child? Why might they be behaving this way in this moment? How might they have misinterpreted my intentions right now because of previous interactions they've had with other humans? And then we want to encourage them to really lean into that child's lived experience. What might life be like? So positive, accepting, curious, empathetic is the ideal pace. And this really is powerful. It takes time, but it really is a powerful framework. We also want to keep in mind that children who've experienced complex developmental trauma usually don't respond well to punitive consequences for misbehavior. And that's typically the parenting strategy that a lot of people begin with is if you misbehave, you'll lose a privilege. What happens is that children are often so insecure in their relationships that when others take things away as a response to behavior problems, instead of understanding the connection that was about the behavior, instead they associate this as further evidence that people don't like them, that relationships are unpredictable, that people are mean. And so it can lead to a bankrupting of the piggy bank, if you will, of that relationship. And so instead we want to orient caregivers toward these three mindsets in this order. You want to first help the child to co-regulate. Then you want to ensure through your affect, through your signaling, that the child feels as secure as possible with you, that they remember that you care about them, that they believe you have their best interests in mind. And only after we have helped the child to settle and helped remind the child that we're in their court, in their corner, then we want to ask the child to reason. Before that, if you know the hand model for the brain, you'll know that when a child is too escalated, they don't have their full capacity for cognitive processing, for reflection, for planning ahead. Once we do get to reasoning, we don't want to necessarily tell the child our reasoning. We want to engage them in some reflective and collaborative conversations. What do you think is important for me to know? What was going on for you? How do you think others were affected? Do they need other things, right? Repair? Will others need things to feel better? What could I have done differently? What could we do differently next time? So a collaborative process of, I'm not going to leave you in this alone. Let's figure it out together. Next time you feel this way or have this need, what can we both do differently? Couple more quick resources, and then we'll open up for some questions. The Child Welfare Training Partnership through the University of Vermont offers training for kin and foster parents. And they have, beyond their foundational training, they have these two training options available. So RPC Plus stands for Resource Parent Curriculum plus Trauma-Informed Parenting Skills. It's a 10-week long class that educates foster, adoptive, and kin caregivers about the impact of trauma on development, attachment, etc. It's free and available across Vermont, both virtually and in person. We've had over 600 caregivers in Vermont who have completed the RPC Plus class. So you may want to ask foster parents, have they completed the training, the RPC Plus training that's available? And if not, recommend to them and their family service worker that they look into that. And then the BPC stands for Breakthrough Parenting Curriculum, Navigating Trauma Across Generations. It's similar to RPC Plus, but the target audience is parents who have been involved in the child welfare system. And a pilot of this course was completed by NFI this past summer, the first in the country. And plans are underway to bring this course to the rest of the state. Right now, the biggest obstacle is a lack of funding, but there's some creative folks who are really trying to get this to be something that's available ongoing. Another resource available for children in the custody of DCF is for you to know that DCF maintains contracts with funding already allocated with a number of different evaluators across the state who can complete comprehensive trauma evaluations for some of the children. There isn't funding for every child in DCF custody, but for those with more concerning impacts. So if you don't have the time and the capacity in your practice, I would understand it, right, to complete a more comprehensive evaluation. Ask family service workers to talk to their supervisors, to talk to their district directors, to find out whether this child could be earmarked for a trauma evaluation. There's often a wait list. It can take a while, but those are really, really beneficial. And sometimes they include findings meetings with the caregivers and the parents, and they're educating everyone. And sometimes they can include ongoing consultation moving forward. We want to be hopeful. Children are really resilient. They can recover. It often takes coordinated treatment and a long time. I was going to share one final case example with that, but instead I want to make sure that you know that there's a resource link here, list here, my email as well. Please feel to reach out. And at this point, I'm going to stop the slide share and answer a few questions. All right, Jill, are there questions in the chat that would be helpful to turn to?
The only things there was some shout outs to RPC as being fabulous, and Amy. And Kira also is reminding everyone that post-permanency also have funds if their interests are adopted or in guardianship.
Great.
Then when you were asking for examples that you might be able to problem solve, and this one might be tricky, someone mentioned the behavior of running into traffic.
Running into traffic. Oh my goodness, that is tough. So knowing nothing about the child, I would imagine, so I would put that in the category of very alarming behavior that will really, really engage other people, and either parasuicidal or suicidal behavior. And so when we see self-harming, when we see threats to hurt others, when we see kids actively doing that, we need to assess to what extent are they genuinely trying to hurt themselves, or are they genuinely suicidal? And to what extent is this the way that they have learned that they can absolutely command other people's attention? Have they learned that things need to be this dramatic in order for others to really stop what they're doing and paying attention to me? That would be my guess, is that that child has learned that the only way they get their needs met is to be really, really, really dramatic. And so therefore we would want to orient toward responding to their needs with much less dramatic asks on their behalf. But we would also need to assess, are they genuinely intending to hurt themselves? So that is a really good question. All right, I want to thank you all for attending. I'm certain you're all busy. We have another minute left. I'm happy to try to answer another question or two, and also happy to return in the future or email me if you'd like. I see, Jill, what you put in the chat. Interested in support from VCHIP regarding children obtaining timely medical care. Please reach out to Jill Davis, med.uvm.edu. Sounds excellent.
And Pete, this is Barb. I just wanted to say thank you so much. I was furiously taking notes, but I know I'll get the slides and where to find the recording of this. So thank you again so much. And thank you everybody for taking your time this lunch hour to join us.
Excellent, Barb. Thank you too. I love being a part of it. All right, take care, everyone.
Take care, Pete. Thank you.